In this video, we are going to be looking at assessment of abdomen, specifically into the auscultation, percussion and palpation. This is the second part of the video. The first part, inspection, will be available in the YouTube of Triplum College of Nursing. Hi, I'm Sharon. I'm working as an assistant professor at M&M College of Nursing. The following are the objectives that we'll be addressing in this video. Although an essential component of all routine physical examinations, the physical examination of the abdomen is a key step in the evaluation of abdominal complaints such as pain, distension, enlarged organs or masses. The examination is conducted in a predetermined sequence starting from observation and then sequentially performing auscultation, percussion and palpation, followed by ancillary maneuvers. The following are the articles required: gloves, inch tape, stethoscope and scale. In preparing the client, before abdominal examination, the client is instructed to empty his or her bladder. Help the client to lie supine with arms folded across the chest or resting by the sides. Slightly flex the client's knees by placing a pillow or rolled blanket under the client's knees. Drape the client with sheets so the abdomen is visible from the lower rib cage to the pubic area. Privacy is essential. Warm hands are essential for the abdominal examination. Instruct the client to take slow, deep breaths during the examination process. The following is the sequence of abdominal examination. This differs from the typical order of assessment: inspection, auscultation, percussion and palpation. In auscultation, initially we'll auscultate for bowel sounds. The normal findings are a series of intermittent soft clicks and gurgles are heard at a rate of 5 to 30 per minute. Hyperactive bowel sounds that may be heard normally are the loud, prolonged gurgles characteristic of stomach growling. These are called boborygmi. In abnormal findings, there can be hypoactive bowel sounds, that is, due to diminished bowel motility. Can be because of abdominal surgery or late bowel obstruction. Hyperactive bowel sounds can be because of diarrhea, gastroenteritis or early bowel obstruction. Decreased or absent bowel sounds requires referral. Absence of bowel sounds can be because of peritonitis or paralytic ileus. High-pitched tinkling and rushes with abdominal cramping can indicate obstruction. Let's look at the timing for various bowel sounds. Absent, there is no bowel sound after listening for 5 minutes. Hyperactive, 1 bowel sound every 3 to 5 minutes. Normal, 5 to 30 bowel sounds per minute. Hyperactive, more than 30 sounds per minute. Next is auscultating for vascular sounds. Normally, bruits are not heard over the abdominal aorta, renal, iliac or femoral arteries. However, bruits confined to systole may be normal in some clients depending on other differentiating factors. Venous hums are normally not heard over epigastric or umbilical areas. Abnormally, a bruit with both systolic and diastolic component occurs when blood flow in an artery is turbulent or obstructed, that is, an aneurysm or arterial stenosis. Venous hums, if present, collateral circulation between portal and systemic venous systems, as in liver cirrhosis, may be present. Auscultate for friction rub over liver and spleen. Normally it's not heard, whereas rarely, if heard, they might have a high-pitched rough grating sound produced when the large surface area of the liver or spleen rubs with the peritoneum. They are heard in association with respiration. If heard over lower right area, it can be suggestive of hepatic abscess or metastasis. In continuation, a rub heard at the anterior axillary line in the lower left costal area is associated with splenic infarction abscess, infection, or tumor. Moving over to percussion, first percuss for tone. Normally, there can be generalized tympany which predominates over the abdomen because of air in the stomach and intestines. Accentuated tympany or hyperresonance is suggestive of gaseous distended abdomen. Next, percuss the span or height of the liver by determining its lower and upper borders. Normal dullness is heard over the liver and spleen and a non-evacuated descending colon. Lower border of liver dullness is located at the costal margin to 1 to 2 cm below. On deep inspiration, the lower border of liver dullness may descend 1 to 4 cm below the costal margin. Enlarged area of dullness, that is suggestive of enlarged liver or spleen. This is an abnormal finding. Dullness can also be suggestive of distended bladder, large masses, or ascites. In normal findings, the upper border of liver dullness is located between the left, 5th and 7th intercostal spaces. Abnormally, upper border of liver dullness may be difficult to estimate if obscured by pleural fluid. The normal liver span at the mid-clavicle line is 6 to 12 cm and at the mid-sternal line is 4 to 8 cm. Abnormal findings can indicate hepatomegaly, suggestive of liver tumors, cirrhosis, abscess, and vascular engorgement. Atrophy can show decreased liver span. A liver in a lower position than normal can be suggestive of emphysema. Liver in higher position than normal can be suggestive of abdomen mass, ascites, or diaphragm. Normally, sound produced by scratching becomes more intense over the liver. Abnormally, an enlarged liver may be roughly estimated but not accurately when more intense sounds outline a liver span or borders outside the normal range. Moving over to the percussion of the spleen, normally the spleen is an oval area of dullness approximately 7 cm wide near the left 10th rib and slightly posterior to the mid-axillary line. Abnormal findings indicate splenomegaly. The area of dullness greater than 7 cm wide can be suggestive of traumatic injury, portal hypertension, and mononucleosis. Normally, tympany is heard at the last left interspace. Resonance may also be heard. Whereas abnormally, on inspiration, dullness at the last left interspace at the anterior axillary line suggests an enlarged spleen. Normally, no tenderness is elicited. Tenderness elicited over the liver may be associated with inflammation or infection, suggestive of hepatitis or cholecystitis, which is an abnormal finding. Normally, no tenderness or pain is elicited. The examiner will sense only a dull thud, whereas abnormally, tenderness or sharp pain elicited over the CVA, that is the costovertebral angle, suggests kidney infection, that is suggestive of pyelonephritis, renal calculi, or hydronephrosis. Moving over to palpation, perform light palpation. Normal findings show that the abdomen is non-tender and soft, there is no guarding. Abnormal findings show involuntary reflex guarding, which is serious and it reflects peritoneal irritation. Right-sided guarding is suggestive of cholecystitis. Next, deeply palpate all quadrants to delineate abdominal organs and detect subtle masses. Normal findings show normal, mild tenderness is possible over the xiphoid, aorta, cecum, sigmoid colon, and ovaries with deep palpation. Abnormal findings show severe tenderness or pain suggestive of trauma, peritonitis, infection, tumors, or enlarged diseased organs. Next, palpate for masses. No palpable masses are present normally. Abnormal findings show mass detected in any quadrant may be due to a tumor, cyst, abscess, enlarged organ, aneurysm, or adhesions. Next, palpate the umbilicus and surrounding area for swelling, bulges, or masses. Normal findings show umbilicus and surrounding area free of swellings, bulges, or masses. Abnormal findings show soft center of umbilicus, herniation potential is there, that is a suggestion, and hard nodule in and around the umbilicus is suggestive of metastatic nodes from an occult GI cancer. Palpating the aorta. The normal aorta is approximately 2.5 centimeter to 3 centimeter wide with a moderately strong and regular pulse. Possibly mild tenderness may be elicited. Abnormal findings show a wide bounding pulse suggestive of abdominal aortic aneurysm. Prominent lateral pulsating mass above the umbilicus with an accompanying audible bruit is also suggestive of aortic aneurysm. Next is palpating the liver. The liver is usually not palpable, although it may be felt in some thin clients. If the lower edge is felt, it should be firm, smooth, and even. Mild tenderness may also be elicited. Looking at the abnormal findings, hard, firm liver is suggestive of cancer. Nodularity is suggestive of tumors, metastatic cancer, late cirrhosis, or even syphilis. Tenderness may be from vascular engorgement because of congestive cardiac failure, acute hepatitis, and abscess. A liver more than 1 to 3 centimeter below the costal margin is considered as enlarged. Enlargement is further suggestive of hepatitis, liver tumors, cirrhosis, and vascular engorgement. The following are the references for the topic that was discussed. Thank you.